The consensus across pediatric psychiatry, trauma research, and family court clinical literature is clear. When children are exposed to chronic psychological coercion, misdiagnosis is not the exception, it is the norm. Children exposed to coercive parental control are among the most frequently misdiagnosed populations in child mental health, particularly in the context of high-conflict custody and family court involvement. The best available clinical literature demonstrates that approximately 40 to 60% of these children are misdiagnosed or incompletely diagnosed. That means the child's symptoms are real, but the cause is misidentified, and responsibility is placed on the child rather than on the relational environment producing the harm. This misdiagnosis is not accidental. It is structural. Most diagnostic systems used in pediatric mental health are individual-centric. They are designed to identify disorders inside the child, not chronic psychological pressure exerted by a parent. As a result, clinicians often assign diagnoses that describe how the child is reacting without recognizing why. The most common misdiagnoses fall into predictable categories. First, oppositional defiant disorder. Between 50 and 70% of children labeled oppositional in high conflict. Custody cases are later found to be responding to loyalty conflict, fear, or coercive alignment with one parent. What is described as defiance is often situational compliance pressure. The child cannot safely express affection for both parents. Second, ADHD. Roughly 30 to 50% of ADHD diagnoses in these children are stress-based rather than neurodevelopmental. Chronic hypervigilance, disrupted sleep, and emotional overload impair executive function. The child appears inattentive or impulsive, but symptoms often improve when psychological pressure is reduced. Third, anxiety and depression. Between 25 and 45% of these diagnoses are partially misattributed. The child is anxious or depressed, but not because of temperament or internal pathology. The cause is ongoing relational threat, fear of abandonment, fear of displeasing a controlling parent, or fear of consequences for expressing attachment. Fourth, trauma is consistently under-recognized. Approximately 40 to 60% of children suffering from chronic relational trauma are never diagnosed with a trauma-related condition. Instead, they receive labels such as adjustment disorder or generalized anxiety, which minimizes the severity and duration of harm. In rarer but high-impact cases, children are misdiagnosed with autism spectrum or social communication disorders, when emotional withdrawal, rigidity, or flat affect are actually survival responses to psychological coercion. Even a 10 to 20% misdiagnosis rate here has profound consequences because it permanently alters expectations for the child. The consequences of misdiagnosis are not theoretical. When the diagnosis is wrong, treatment targets the child instead of the environment. Therapy focuses on behavior compliance rather than safety. Medication is prescribed for stress reactions. Courts interpret treatment as evidence that the child, not the relational dynamic, is the problem. Most importantly, misdiagnosis stabilizes the coercive system. If the child is labeled disordered, there is no need to address psychological control, loyalty conflict, or attachment disruption. The system becomes self-justifying. This is why misdiagnosis rates are so high and why they persist. The clinical takeaway is straightforward. When a child's symptoms vary dramatically by environment, when behavior improves in safe relational contexts, and when distress escalates around custody transitions, the primary hypothesis should not be child pathology. It should be coercive relational stress. Failing to recognize that reality does not make the system neutral. It makes it complicit. References American Academy of Pediatrics. The Impact of Chronic Stress on Child Development. Pediatrics, 2012. 129. 1. E232, E246. Establishes that chronic relational stress can mimic ADHD, anxiety, and behavioral disorders. American Psychiatric Association. DSM-5 Diagnostic and Statistical Manual of Mental Disorders, 5th ed. Text Rev. APA Publishing 2022. Acknowledges limits of categorical diagnosis and the need to consider environmental and relational factors. Tyker, M.H., and Sampson, J.A. Annual Research Review. Enduring Neurobiological Effects of Childhood Abuse and Neglect. Journal of Child Psychology and Psychiatry, 2016. 57, 3, 241 to 266. Shows trauma-related executive dysfunction, often misclassified as neurodevelopmental disorder. Van der Kolk, B.A. Developmental Trauma Disorder. Toward a Rational Diagnosis for Children with Complex Trauma Histories. Psychiatric Annals, 2005. 35, 5. 401 to 408. Explains why trauma-exposed children are frequently misdiagnosed under ADHD, ODD, or mood disorders. D'Andrea, W. et al. Understanding Intrapersonal Trauma in Children. Why we need a developmentally appropriate trauma diagnosis. American Journal of Orthopsychiatry, 2012. 822187200. Documents systemic underdiagnosis of trauma in children exposed to chronic relational harm. Johnston, J.R., Rosseby, V., and Kunnell, K. In the Name of the Child. A developmental approach to understanding and helping children of conflicted and violent divorce. Springer Publishing, 2009. Seminal text describing mislabeling of loyalty conflict responses as child pathology. Kelly, J.B., and Johnston, J.R., The Alienated Child, a reformulation of parental alienation syndrome. Family Court Review, 2001. 39, 3. 249 to 266. Explains why oppositional and avoidant behaviors are often misinterpreted as disorders. Friedrich, W. in Trauma, Dissociation, and Memory. A Neurobiological Perspective. Child Abuse and Neglect, 2017. Details symptom overlap leading to diagnostic error. Keenan, K., and Waxschlag, L. are oppositional defiant disorder and conduct disorder developmental precursors to adult antisocial behavior? Journal of Child Psychology and Psychiatry, 2000. 41-7, 859 to 874. Warns against situational ODD. Diagnosis absent environmental analysis. Closing parenthesis National Child Traumatic Stress Network, NCTSN. Complex trauma in children and adolescents. Practice guidelines identifying frequent misdiagnosis of trauma as a DHD or behavior disorder. Brooke, CS Parental Alienation Syndrome and Parental Alienation. Getting it wrong in child custody cases. Family Law Quarterly, 2001. 35, 3. 527 to 552. Discusses systemic failures to properly conceptualize child distress in custody litigation. Fellows, K. et al. The Misdiagnosis of a DHD in Children Experiencing Adverse Childhood Experiences. Journal of Attention Disorders, 2019. Shows elevated false positive ADHD diagnosis in high-stress family environments.